Hello everyone. I think we could start this webinar session. It's my pleasure to say a few introductory words and before handing over to our special speaker, Rita Babeluk. Very warm welcome to the 6th edition of the VIPROM Webinar Series. Following the last excellent webinar by our Italian colleagues 2 weeks ago on the topic of medical assessment and securing evidence, today's webinar will focus on risk assessment and safety planning as another very important topic and element in the field of victim protection in medicine. A brief introduction of the two of us, my colleague Paul Herbinger and I, Michaela. We are both social scientists at VICESSE and involved in the VIPROM project. VICESSE is the Vienna Center for Societal Security, which is a non-profit research institute that conducts a range of research projects in the area of societal security, including domestic violence as one of the focal points of our research profile at the institute. We are mainly funded by European projects, but also national funds. But now I'm delighted to welcome our special speaker, Rita Babeluk. She will hold today's webinar session. She's a doctor in the trauma surgery in Vienna, which is the biggest hospital in Vienna, the General Hospital, with a special focus on domestic violence, and has conducted the national VIPROM training courses. We are very pleased and fortunate to have you, such a knowledgeable expert, on board for these important training courses on domestic violence in the medical field, which will prepare medical professionals for dealing with these patients. And now I will hand over to you directly to introduce yourself in more detail and also for your talk. We are very much looking forward to it. Thank you very much for being here and sharing your experience and knowledge with us on this important topic.
Thank you very much for this kind introduction. As Michaela said, I'm a trauma surgeon. I'm an attendant at the medical university, or consultant in Britain, at the medical university in Vienna. And since we unfortunately treat a lot of victims of domestic violence in the trauma department on a daily basis, I have been in contact with this field from the very beginning of my medical training and found interest in that. And for the last 1.5 years, I am the head of the outpatients clinic that specializes on victims of domestic violence in our trauma department. So let's go into the topic now, enough about me. So this is our plan for today. First, we will evaluate what is risk assessment. I will show you the indicators for high-risk cases. Then I will present to you some assessment tools that facilitate the risk assessment. Then we go into the topic of safety planning for our patients. And then I will present to you a case study from my clinical practice. And in the end, we will find time for the conclusion and the discussion. As you probably heard before in previous webinars, 60% of women that experience partner violence primarily seek help within the healthcare system. 23 of those seek help in a hospital. So the recognition and the right treatment of violence plays a significant role of the healthcare system. You also probably heard about the Rita system that gives a guideline how to treat those patients, which is a routine screening of every patient to ask directly, kindly and non-judgmentally about a history of violence, to document the findings, to assess the patient's safety, and also to review options and provide referrals. As I said, today we will focus on the assessment of the safety. So what is risk assessment? First, it is a collaborative set of strategies and measurements to evaluate the likelihood of possible further acts of violence. This includes, on one side, facilitating the access to support services, to seek secondary consultations, and also a continuously assessing of the risk. A risk assessment, it is not a one-time point happening or evaluation, it is important to assess it at every appointment of the patient. It is a continuous proceeding. It is crucial to prevent sending the victim home into a potential life-threatening setting. The goals of safety planning are first identifying the presence of risk factors, which may increase the likelihood of an escalating of the violence and can lead to reassault. It includes psychological and psychosocial traits of the perpetrator and the victim. So it's not only the victim and the perpetrator, it's both, because it includes the dynamics between the victim and the perpetrator in their relationship. Sometimes the risks can vary between individuals, the relationship, the community, and the social levels, and other risk factors are found constantly across studies. Sometimes risk factors can vary within a country, for example, in a rural setting or in an urban setting, and some are not because of causal factors and may not be triggers for domestic violence. We will discuss this in detail in the next minutes. Here I show you possible indicators for high-risk cases. First, there is, for example, a sudden change in the perpetrator's behavior. You have like a possible escalation of the violence in the last few weeks. When the patient tells you he or she changed all of a sudden. It can indicate a high-risk case if the victim tells you things like, he gives me creeps, or she has that look in her eyes. So it is crucial if the patient communicates to you that he or she is afraid of the perpetrator, you should take this seriously. It is a high-risk indicator if the perpetrator shows violence against pets or has substance abuse like alcoholism or drug abuse. It is a high-risk indicator if in the past violence against the neck happened, like strangulation. Why is this? This is explained by the fact that even a not medical expert understands that when you strangle a person, you may accept the possible death that happens quite fast. So this is a situation of escalation of the violence. Another risk factor is violence during pregnancy. And this is because if you show aggression against a pregnant woman, you endanger not only the woman, but also the unborn child. If there is a outspoken, announced separation or divorce, or a separation or divorce that happened shortly before. This is a high risk factor because due to the mechanism of domestic violence, which often includes having power over the partner, and when the partner now, the victim, announces a separation that can lead to a high escalation in the relationship, in the violence, since the perpetrator might lose this power. Also, most femicides that happen in the phase during or short after a separation of the relationship. If the victim has a new relationship, or if the perpetrator lost custody of the children, that might also lead to escalation, or if the perpetrator has already violated restraining orders in the past. So, as I mentioned before, if the victim mentions fear of the perpetrator or mentions that they hesitate to return home, it is crucial to take the safety concerns seriously, since often people who experience violence recognize immediate danger. So, how to provide, or what is the next step that you do in protect and provide safety for your patient? So safety planning should always be accompanied by a discussion of safety measures, which I will present to you in the next slides. It is important to assess whether there are childs involved and if those children are safe. So if children are involved, the child protection services must be involved. Further, if you admit the patient, a victim of domestic violence, to your wards, it is not only crucial to protect the patient, but also to secure the safety of the staff. So you should do an information restriction and visit bans. Because sometimes in the beginning it is not clear who the perpetrator is and if the safety situation is given for the patients. And also you should ask the patient for a person of trust who you can give information to. And if the patient doesn't have a person of trust, then you don't give information to third people. Also, the clarification of social factors in the case of discharge should be clarified. Which are the challenges for high-risk cases? There are special challenges if the perpetrator and the victim have shared children. This difficults the situation a lot. If there is a close-knit family network that can be utilized by the perpetrator to gather information or to maintain pressure on the victim. Also, sometimes data protection regulations hinder the involvement of additional professionals. And also the lack of information or problematic protection for the victim after conviction and imprisonment of the perpetrator can be very challenging. So as I said before, the specific risk factor separation is a very hot topic. It can all very often lead to the escalation of violence. International crime statistics show a recidivation rate for domestic violence of 15 to 6 up to 60%, depending on the study. And not only physical violence can be part of the pattern that perpetrators use in the time during separation, but also there are other tactics to maintain and reinforce the power imbalance, which is, for example, judicial or legal violence, when the perpetrator uses the legal rights to continue perpetrating violence, for example, pursuing child custody or visitation sites. There can be financial abuse, for example, to avoid financial obligations or prolonging legal proceedings or hide the assets. There can be threats to children's safety and also character defamation within the family or between under friends, and of course persistent harassment and stalking. So how can we now assess the risk on, let's say, standardized method? Because so far I only told you different risk factors, but we always need standardization in medicine. The first tool, there are different tools to assess this. The one that I'm going to present as well, and it's the internationally probably most used one, is the Campbell Stage Assessment tool. But there are also other tools like the DASH tools or the in German the dynamische Risikoanalysesysteme. The Campbell Stage Assessment tool is a questionnaire of 20 questions that ask about mainly the high risk factors that I told you before, like has the physical violence increased in severity or frequency over the past year? Have you left him after living together during the last year? Other risk factors like, is he unemployed? Does he have a weapon at home? And all those questions are yes and no questions. And the more yeses there are, the higher the risk. So here on the side, you can see that 0 to 7 yes is a possible risk, is a low risk. 8 to 13 a yes is an increased risk. 14 to 70 yes answers are a high risk, and more than 18 yes mean an extreme high risk. These are questions that the VIPROM project suggests for a shorter version of the Campbell assessment tool. Here are questions like, is it safe for you to go home, which implies the importance of the victim's feeling of safety, as I explained before. Are you afraid? What are you afraid might happen? What has the perpetrator threatened? Are there threats about the children? Has he ever or she ever tried to strangle you? Has he or she beaten you when you were pregnant? These are just examples that I read now. Here again, the more yes questions there are, the higher the risk. So if you may have assessed now there is a high risk, what are the next steps to do? You have to make any consequences. So the next step might be to make a safety plan. This includes several aspects, like, for example, to talk about to prepare the patient about a possible escalation. So principally, after risk assessment, there are two ways. First is the patient wants to set further steps, which is might be a police record, further legal steps, and also leave the victim, leave the perpetrator, go to a women's shelter, whatever. Or sometimes they decide to go back. We have to accept that, and with every revisit, prepare the patient and evaluate a safety plan that, in case of escalation, they have an escape plan that they can pursue even in an acute situation. So first step is find a safe place to go. You ask the question, the patient, if you need to leave your home in a hurry, where would you go? This can be a friend's place, this can be a women's shelter, this can be the hospital. There are several possibilities, but make the patient think about it for the first time, or think about it, make a plan for the acute situation. The next step is planning for children, if there are children. Would you go alone or take your children with you? To plan the transportation. How will you get there? Can you take a cab? Can you take the subway? Where is it where you want to go? What items do you take with them? Do you need to take any document, keys, clothes, money when you leave? And what is essential? And where do you keep it? Like a little emergency case, for example, that you can shortly take, and in case you have to run away quickly. How are your financials? Do you have access to money when you need to leave? Where is it kept? And can you get it in an emergency? And also to assure that there is support of someone close by. Like, is there a neighbor you can trust? And maybe talk about the violence, who can call the police or some help if they hear a sound of violence, or is this impossible? Sometimes it's not possible. So these are questions that need to be discussed before, so that in an acute situation, the patient already at least have thought about it before. As I said, safety planning is, or like risk assessment, is an ongoing process. Maybe not the first time you see a patient, everything can be discussed, and this would also maybe be too much information. So it is crucial to make follow-up appointments and to take a look at the safety situation every time you see the patient, to reevaluate it each time. Of course, this is always for all the medical, or everybody that works in the medical field. Documentation is everything. unfortunately. We have to document all these plans. But if you give the patient the documentation, the documentation can be either just for you or the version that you give the patient. But if you give the whole documentation to the patient, please warn the victim that it will not be found by the perpetrator, because this can also lead to further escalation. So what to do now in an acute case? As I said before, my main job is being a trauma surgeon. So we don't have a lot of time for each patient. It is almost always an acute situation. So what to do in an acute situation? So first, it is important to find out if the case is already known by the police and if the patient wants to have the police involved. This also must be documented. You can ask if an accommodation is possible with a friend or a family. Sometimes this is not possible because the perpetrator uses friends and family against the victim. So you have to be careful with that. You can contact the violence protection centers or women's helpline, or admit the patient to a women's shelter. Here it is important to say that if the patient goes to a women's shelter, you have to tell them that they take a cab and not the public transportation, because the perpetrator might find them if they walk around the hospital, for example. I can only say how it is in Vienna. If we order a cab for a victim of domestic violence to admit it to a women's shelter, and even if the victim doesn't have money for it, the women's shelter pays the taxi. It is important to protect the children if there are children. There are crisis centers, or sometimes accommodation with relatives is possible, or in some women's shelters, children can be admitted as well, together with their moms. And in cases where there is no admission to women's shelters or with friends or relatives possible, you can also admit the patient to the hospital. But here, as I said before, it is important to do information restriction and visit bans. It is important to know that almost 1/4 of all victims of domestic violence exhibit self-harming behavior, and also the risk for suicide is very elevated. So it is crucial to actively ask for that and evaluate that as well. And if this is the case, that you address and refer immediately to a psychiatric clinic if necessary. So I already mentioned a little bit before, there might be cases where the patient does not want a report at the police. So how do we deal with that? What do we do here? First thing is that you don't put the patient under pressure. Don't make them feel guilty. I think sometimes this is the most difficult part to do, because you have, or I have the feeling there is something happening that is not right, and the patient does not want to do anything against that. But it is important to accept the patient's will and not make them feel guilty. Maybe next time they will open up. The exact documentation of the injuries, even minor injuries, are a legal obligation. We heard that in the last webinar very extendedly and very good, how important the documentation is. Nevertheless, even if the patient doesn't want a report, you should offer and recommend a photo documentation. Those photos remain stored, and in case that they want to make a report later, they can be picked up and by the police. So you have to also tell the patients that making a photo does not mean that the case will be reported, but it's a that it's stored, and in case that they want to make a report later. And especially in cases that don't want a report, you should arrange a follow-up appointment, because maybe later in the not that acute situation, the patient will change their mind. But very important, children and persons that are not capable of giving consent must always be reported. So if it is a case where the victim is a minor or not capable of giving consent, those cases must be reported to the police. So now already we come to our case study. This is a case of my outpatient clinic for domestic violence. They presented a woman which was 28 years old. She was pregnant in the 18th week. She presented to the trauma emergency department because her husband has beaten and strangled her. She tells that she is regularly beaten by her husband, but this time she was choked for the first time as well. She said that she moved to Vienna recently, so she doesn't have any friends or relatives living in Vienna. And she does not want the police involved because she is afraid of further escalation of the situation. And would invite you to write in the chat which are the red flags that you see when a case like this is presented to you. There are a lot of answers already. I'm very delighted. So first, a lot of times strangulation, pregnancy, the escalation of the violence, which is a strangulation. She is socially isolated since she recently moved here, and the patient is afraid. Very good. So next question, what do you do now? The patient doesn't know anybody. She's afraid. She doesn't want a police report. What are your next steps? Okay, I will read some of the answers to you. So document her injuries, safety plan, give her informations, document injuries, safety plan, direct her to a women's shelter, discuss to her safety and that of her unborn child. While she does not want a report, address what her plans are to keep her safe. Very good. All very, very good answers. Thank you very much. Ask if involvement of violence prevention centers experts. Thank you very much. So you said the examination, the documentation, and the treatment of the injuries, of course. Here in this case, also other medical experts, I think one of you also wrote that. Since first the patient was pregnant, she should see a gynecologist to check whether the baby is fine, and also ENT assessment because of the strangulation. It is important that a specialist looks into the throat to see whether there is no swelling and no danger for the breathing. And you can organize or offer the organization of a place in the women's shelter for the night, or make a further planning of the procedure. So we are already at our conclusion. The challenges, as I explained, are first data protection. There is a limitation of the disclosure of information to other professionals. Another challenge is social isolation. The offenders may use the family networks or the friend to exert pressure. After imprisonment, sometimes or very often, there is a lack of protection and insufficient information for the victims. And another challenge are repeat offenders, because the recidivism rate is very high. I want to remind you of the tools that support risk assessment, like the DASH risk assessment or the danger assessment tool according to Campbell. They give a very standardized and easy way of risk assessment. Also in acute situations, since these are only yes or no questions. that sometimes, yeah, that you can ask the patient very quickly. What are my recommendations? Of course, when you deal with victims of domestic violence, sensitivity is crucial. This would be a good recommendation for all the patients that we treat, but especially the ones that are affected from domestic violence, and also to avoid to blame them. A non-judgmental documentation of all the findings, and maybe including and also the minor injuries is very important, and the safety situation in every contact with the patient. So as I said, it's an ongoing process. It's not a single time event. What are the long-term strategies? Of course, to promote the interdisciplinary cooperation between the police, the medical personnel, and the Violence Protection Center, to establish a regional network of support organizations, ongoing training on domestic violence, risk assessment and safety planning, and also to use digital resources and platforms to facilitate the access to information and tools. So with this slide, I want to thank you very much for your information. So thank you very much again.